Thank you very much for asking me to speak today. So as Nick said, I'm a consultant surgeon here in Leeds, and most of my elective work is taken up with sarcoma surgery, and GIST falls under that umbrella. Probably about 20% of what I do is GIST and 80% is other sorts of sarcoma. And my involvement in GIST tends to be the more complex cases, so recurrence, peritoneal disease. One of my colleagues, Professor Toogood, tends to take the lead in the liver metastases side. I'm also the lead abdominal surgeon for the Yorkshire Regional Sarcoma Service, which is the multidisciplinary team in Leeds, which is responsible for guiding the management of GIST patients from a wide catchment area. So most of Yorkshire, Sheffield do also manage GISTs, but we take all the GISTs from West Yorkshire and right across to Hull, down to Doncaster. So it's a catchment area of about 4.5 million people. So what is metastatic GIST? What are metastases? So we talk about primary tumours, which for GISTs are usually in the stomach. You can see the blue dot there, and that's where the tumour first arises. And metastases are tumour spread away from that primary site. You know, we sometimes talk of it in terms of seeding. So they're cancer cells that have got into the bloodstream and spread and then started growing at other sites. If you look at the literature about GISTs, it depends which country you're looking at, which patient population you're looking at. But around 15 to even up to 50% of patients with GIST will already have spread when they're first diagnosed with the condition. So metastatic GIST is common. It tends to spread to two particular places. The first place is the peritoneum, and that's the lining of the abdominal cavity. Your bowels and your liver all sit essentially in this almost like a balloon. And you can get little seedlings of cancer spreading to the peritoneum, as you can see with those blue dots that have appeared. So about 50% of metastatic GIST will be the peritoneum. It also spreads quite commonly to the liver. So about a quarter of metastatic GIST will be in the liver, and about a quarter of patients will have both. So what are the treatments for metastatic GIST? I think the first thing to say is, more than a lot of other diseases, everybody's different with GIST, and the treatment will depend on where the primary tumour was, how aggressive that primary tumour was, where the spread is, how much spread there is, the size of the spread, when it's occurred. So you can't say that this is how you treat metastatic GIST. It's very, very individual. Having said that, on the whole, most patients will be given some form of drug therapy at some stage during their treatment of metastatic GIST. Imatinib is the commonest one that's used, also known as Gleevec. That tends to be the first option. And then there are other options available if that's not suitable. And the question is surgery also appropriate for treatment on top of that? So talking about the two main areas for metastases separately, the first one, peritoneal metastases. So this is a set of pictures from a journal article about metastatic GIST, and you can see this is a CT scan, and you can see these areas that have been highlighted here and here, which are up against the lining of the abdominal cavity, really at the back behind the six-pack, which we all have got. Some more hidden than others. And I don't know how well it projects, but you can see here on this picture here, this loop here is the small bowel looping round. This yellow area, this is the fat, which has the blood vessels to the small bowel running through it. And that you can see these little areas here and here, which that's metastatic gist on the peritoneum that lines this area of bowel. And an example here of what potentially can be done. Here they've gone in, opened up someone's abdomen and gone in and removed all those areas of metastases. You can see this is the biggest one that you could see on the scan here, but then they've also gone in and removed all the small little areas that they can see. So that's quite extensive surgery to do that. But if you think you can get everything out, then it is often something that is worth doing. This is a patient who I've operated on, who was referred to us in Leeds. They'd had a small bowel gist removed quite a while ago, actually, and had been on long-term imatinib. And 9 years after they'd had their original operation, they identified on CT scanning a new area here, this white dot, that was well away from where the previous bowel surgery was, and this hadn't been present on the previous scans. We monitored it for a little while, for sort of 6 months or so, and it did grow a small amount over that period, which suggested to us that firstly it was something to worry about, but also that the imatinib wasn't controlling it. So I went in and resected this. There was nothing else obvious around, and the patient made a good recovery. Seem to have lost a slide.
Can I just ask, was it just metastases?
Yes. So we sent it off to have a look at under the microscope, and yes, it was. I did have another patient. I don't know where that's gone. So liver metastases, as I said, they're also common in GIST, and we can take advantage with liver metastases in that more than any other organ in the body, the liver has a brilliant capability to regrow. And even the ancient Greeks knew about this. This is Prometheus, a statue from the Louvre, and he was a Titan in Greek mythology who stole fire from the gods to take back to humans, and upset Zeus when he did this. So he was bound to a rock, and every day Zeus sent an eagle to go and eat his liver. And then it grew back overnight, and then the next day the eagle came again and ate it again. So, eternal damnation. But fortunately, we've been able to take that knowledge and use it to do really quite large operations on the liver for liver metastases. And this is the same for any kind of cancer spread, be it bowel cancer and other cancers. But you can take actually up to 3/4 of the liver away, and the patient will survive, and that liver over 6 months or so will grow back to its original size. We divide the liver up into sort of 8 segments, and these show all the sort of various things you can do depending on where the metastasis is in the liver. So you can take out most of the right side of the liver, you can take out most of the left side, you can take out 3/4 of the left side or 3/4 of the right side. Or you can just take out one of the 8 segments, or if you've just got a small metastases sitting on the edge of the liver, you can just take that out. Or you can do a combination of these depending on where the metastases are situated in the liver. So in terms of liver surgery, there's lots of potential options available. So again, this is from the same journal article I talked about previously. So you can see this is a CT scan at the top here. This grey area is the liver. The white bits are veins running through it. And this black area here is a large liver metastases from a GIST. And in this paper, they were treated with imatinib, and you can see that actually that was really quite effective. So the imatinib shrunk the tumour by almost half. It then started to grow again on the imatinib, which would suggest that the imatinib was starting to lose control. So they went in and operated, and you can see this is the left side of the liver here. Stomach's down here, and then you've got the whole of the rest of the right side of the liver, which is sort of hidden away under here. So what they did is they essentially went in and took the left side of the liver out, and this is what they took out. And you know, if you've just got a single metastasis, and you can do that, and you can make sure that you've got it all out with a margin of normal liver alongside, then that's potentially an operation that can cure that patient. Now you can even do liver surgery like that nowadays with keyhole surgery. Now keyhole surgery for primary GIST cancers in the stomach, as you know, that's very much, if the tumour's suitable, that's sort of the standard of care almost, if it's a small enough tumour. For liver surgery is potentially more complex than that. So the use of keyhole liver surgery is still in development, really. And again, it depends very much on where the metastases are in the liver, the size of them, how many there are. But certainly for smaller liver resections, they're increasingly being done with keyhole surgery. And this is something that is offered by my liver colleagues in Leeds. For a old-fashioned, as we might call it, liver resection, you'd have a big cut either down the abdomen and then across, or even right over the top. So quite a big cut. Whereas with keyhole liver surgery, you can do it all through these little 5 or 10 millimetre ports with long instruments that go in. And this is a special keyhole instrument that we use to divide the liver. Here they're doing an ultrasound of the liver, again through the keyhole. So we've got special keyhole instruments that you can put in, and then that gives you a very detailed ultrasound of the liver, so you can see exactly where the metastasis is and plan your surgery. And then this is an instrument that we use to divide the liver, and you can see here the liver's essentially being split in half, and even more so here, to remove the diseased area. Now, even though it's keyhole surgery, you've still got a piece of liver that you need to get out, and so you do need to make a cut to actually get that bit of liver out. And what you don't want is it breaking up inside and potential for spreading cancer cells inside. But this is still a much less invasive operation than the old-fashioned cut, and we know from keyhole liver surgery that patients are able to get home sooner. They're able to get back to normal activities quicker, and generally the sort of patient experience of the operation is much better. Something else that's available to us for treatment of GIST liver metastases is what we call ablation. And this is usually done through the skin. So you use an ultrasound to show you where the metastasis is, and then you put this very narrow probe through the skin into the liver until you're right in the centre of the tumour. And there's various techniques that you can use, various ways of ablating the tumour. The commonest is radiofrequency, but also microwave. The principle is essentially the same. It heats up at the end of the probe, and then it basically burns that liver metastasis and kills it off. Again, it's something that's offered here in Leeds. It is quite selective in terms of when it's suitable. The tumour has to be less than 3 centimetres or so, and that's because the heat from that probe only really carries about 3 centimetres. So a bigger tumour than that, you're not going to get the heat out to the outer area of the tumour, and you're going to leave cancer cells behind. The other thing is that you have to be careful about doing it very close to some of the main structures in the liver, some of the main blood vessels and bile ducts, again, because it can get very hot, and actually you can get damage to those blood vessels or bile duct from the heat. It tends to be an option if we decide that people, for whatever reason, aren't suitable for surgery. So maybe they've got other medical problems that mean we don't think they'd get through a big liver operation. If you look at the results of this compared to doing a proper liver resection, an operation, the chances of the cancer coming back again are less with the operation. So this tends to be more, as I said, in people who, for whatever reason, we're not able to do an operation on. So, in summary, what's our approach to people with GIST metastases? As I said, it can be a combination of treatment. It usually involves treatment with the oncologists, with imatinib or some of the other agents are available. And it may be that we give people a trial of imatinib first and see what happens over a short period of time, and then go in and operate. And that might be a combination of open surgery, keyhole surgery, ablation. And as I said at the beginning, every patient's unique. And it depends very much on the pattern of disease they've got, their general health, amongst other things. What's very, very important is that, well, GIST patients as a whole, but particularly patients with metastatic GIST, are managed as part of what we call a multidisciplinary team. And I'm sure a lot of you will be aware of that, and I'd hope that anyone here with a GIST, their care has been discussed at a multidisciplinary team. And that essentially means you have a selection of experts covering different areas. So we have a weekly meeting every Monday, it's the sarcoma MDT, but that also covers all our GIST patients. And there's surgeons there, there's oncologists there, radiologists to look at the x-rays, pathologists, who are the people who look at the specimens down the microscope and diagnose GISTs, nurse specialists, physiotherapists, and all of those people are inputting into the management plan for these patients. And I think that's vitally important and means that every area of the patient's care is covered, and you have input into that. So how well do we do in terms of treating people with GIST metastases? Again, if you look into the medical literature, there's lots of different reports from lots of different hospitals, from lots of different countries, treating people with metastatic GISTs in lots of different ways. So these are very much ballpark figures. Now for peritoneal metastases, this was a series of patients who were treated with imatinib and then went on to have surgery. And if you looked at those, 89% of them at 2 years had had no further growth in their cancer over that time. So I'd say that's promising results. In terms of people with liver metastases, and again treated with imatinib and went on to surgery. So all of these people were suitable to have surgery. 3/4 of those were still alive at 5 years. So there's certainly work to do in terms of improving the outcomes. But, you know, metastatic GIST is not necessarily, you know, doom and gloom. And there are options available to you, to us, with good results. Thank you very much. I think we're going to take questions together at the end.
Thank you very much.